Because somehow they may have coped earlier in life, but as they go on, the demands become more, and then they exceed their limits in terms of what they can do. And then, of course, there's impairment in everyday functioning. So basically, this makes up the definition that we use. So just drill in a little about social communication, because it's a big component. And the component that is more consistent, the other component of restrictive repetitive behaviors disorders, but the ones that will really point to us to AS, which has social interaction, having social tasks, peer-related social competence, social reasoning, conflict resolution, cultural inferences. And then we have social cognition, which is the way in which people process, remember, and use information in social contexts to explain and predict their own behavior and that of others. Much of what we see in children and other individuals who have autism, they cannot explain their own behavior. They do not understand, or they have very limited understanding of their own emotions, let alone the emotions of others. So this is a problem of social cognition. Now, again, about social interaction, we need to note that we human beings, whether we like it or not, we are hardwired for social interaction. And this starts right from conception, the formation of the part of the brain that is for social interaction. Mirror neurons in our brains are stimulated when we are interacting with other people. And that's why you meet someone who is genuinely smiling, they will invoke some kind of smile in you as well. So literally, when we are talking to someone, pathways in our brain lights up to mirror the emotions and behaviors that this other person is conveying. We are hardwired to interact and connect with others. So you will see in the symptoms of ASD that this is really deficient, and that's why we call it deficits in social communication. And then the other aspect is pragmatics that I want to explain a bit. It's an English language, but when it comes to ASD, this is the ability to use language for different purposes. Yes, to greet. We see that when we have a child who is coming into the consultation room and they're on the spectrum, they might greet us with a slap, or they might say happy birthday. Presently, we had one who came in and said happy birthday as a form of greeting. So the language for different purposes about demand to request is, and the parent described that this child comes and gets my hand as if it's an object, and will take me to what they want. So you know that there is an inability of use of language for different purposes. The second aspect of pragmatics is the ability to adapt language to meet the needs of the listener or the situation. For example, talking differently to a baby versus
we can no longer see the screen, Catherine.
Okay, I don't know where I lost you. I have, I can, I'll reshare the screen.
Okay.
Yeah.
Thank you.
Okay.
We are back. Thank you.
Back. Yes. So being aware of the listener's knowledge and giving more information or less when needed. Then lastly, about pragmatics is following the often unspoken rules of conversation and storytelling. A story has the beginning, the middle, and the end. So when you ask someone who is on the spectrum and they have speech, they will be so disorganized in their storytelling. They might want to start from the end, then go and begin, and then end up in the middle. So, and the other one is taking turns in conversation. You say something, they listen, they also say something, they add on, so that the conversation goes on and on. Looking at the speaker or maintaining eye contact, standing an inappropriate distance from the speaker, that is something we often also see. Not long ago, I think last week, I had a 15-year-old, we were making a diagnosis for the first time. And I asked him to follow me. And he nearly entered between my legs. And that is how he followed me. So that alone was like, okay, there's something here. And then, of course, using facial expressions and gestures. So that is about the other social communication, restrictive, deficits in social communication. The second aspect of the definition is restrictive repetitive behaviors, which refers to a broad class of responses characterized by their repetition. Yeah, maybe just turning around, so repetitive behaviors and rigidity or inflexibility, and then frequent lack of obvious function. Someone gets the pen and they're just twirling it around like this. When you look at what they are doing, it lacks obvious function. What function is it playing? Then repetitive behaviors described in individuals with ASD include stereotyped movements, motor movements, repetitive manipulation of objects. You give them a car, a toy car, they will turn it upside down and begin to turn around the wheels of the car. Repetitive self-injurious behavior. This is very disturbing and challenging to manage. Specific object attachments. They can get a stick in the compound or a bottle, an empty bottle, and they will hold on to it the whole day. They'll even go to bed with it. And then compulsions, rituals and routines. Once this is how they want their plate to be set, you set it differently, tantrums. An insistence on sameness, repetitive use of language, and the narrow circumscribed interests. So having gone through what autism is, it's important to just have an idea of how big is the problem of ASD. Worldwide, it is estimated that it's 1% of the general population. However, in the US, there's been records of increased prevalence of about 178% since 2000, the year 2000. So you can see right now it is 1 in every 54, starting from down here. Continues to go up and up. In Uganda, there was a study by Professor Angelina Kakoza who reported 1%. And today we had a journal club by Dr. Rinda Anita who found much higher prevalence, but this was in the neurology clinic looking at children between 2 and 9 who reported to the neurology clinic. And I think she reported a prevalence of about 26. Other studies, but they may not have been published. So you can see that it's not a problem that we should just wish away. We really need to confront this problem, especially now that infant mortality is reducing, and management of infectious diseases that takes up much of many people's times, and even the parents may also be perhaps getting under control. Okay, we would not do justice to this talk if we do not talk about the causes. What causes ASD? Everybody who comes to the clinic wants to know, what is the cause of ASD? What is it and what causes it? And this is what we know so far, that there is no single known cause of ASD. Remember, it's an heterogeneous disorder with varying symptoms. The same symptom you find in this patient might not be the one you find in the other. Yes, and varying severity. So given the complexity of the disorder and the fact that symptoms and severity vary, there are probably many causes. Both genetics and environment may play a role. So the current understanding is a combination of genes, and genes, for some of us who may want to understand it, what it is, it's the basic physical and functional unit of heredity. So it's a combination of genes and the environments in which we live, that in which the baby grows and comes to live, that increase the risk that a child will develop autism. Now we need to take note that some gene changes are also found in normal people. So there are those gene changes that are found in people with autism, and then they are also found in normal people. That even makes it more complex. And then not everyone who is exposed to the environmental risk factors develops autism. So what are these genetic risk factors? How do we get to assess or know? It runs in families. Indeed, in our clinics, we see siblings, which is very disheartening that in one family, they have same mother, same father, but they have 3 children and all of them are on the spectrum. Twins, we've seen a number of twins that both twins are on the spectrum. So changes in certain genes increases the risk of a child developing ASD. So you ask yourself, what is it that can cause these changes in genes? Is what we call epigenetics. When the backbone of the gene is intact, but the methyl group is the one that is changed. So if a parent carries the gene, the parent may pass this gene on the child, even if the parent has no autism. This is something that sometimes we also do the assessments, and really there seem not to have to be a family history, but there we are with a child who is on the spectrum. So other times it arises spontaneously in early embryo development. So there are all these other ways that the genetic risk factors cause this. And then environmental risk factors. What we normally say is that, well, you have the genes, perhaps currently we can't do much about the genes, but we can do a lot about the environmental risk factors. As you can see, that advanced age of either parent above 35 years, you're increasing the risk of having a child with ASD. So can we have children a little earlier, not in adolescent age, but appropriate age. And then pregnancy and birth complications. In our clinics, we see this as very prominent. Nearly all children we see on the spectrum have birth complications. And what are we doing about it? I hope that we will begin to think through how to make, or if it is not already being done, I think Busoga region is doing a lot already. And then prematurity of less than 26 weeks. Low birth weight. Multiple pregnancies, I've mentioned that. Pregnancy spaced less than 1 year. And of recent, literature has it that sodium valproate, taking this particular medication, increases the risk of having. We shall see more risk factors in the next coming slide. But there are also those factors that decrease the risk. And this is what we don't talk about. I think we really must talk about factors that decrease the risk. For example, prenatal vitamins, taking folate 6 months before conception, especially if you already have a child that is on the spectrum. The next pregnancy, you need to plan and begin to prepare your body so that you may not eliminate the risk, but you reduce the risk. The other thing is about vaccines. There's been a lot of talk about vaccines causing autism, but it has no effect on risk at all. Actually, vaccinating your children is protective against many other killer diseases. This slide here is from a paper that was published, I think 2019, and it was a consensus paper, evidence-based risk factors and protective factors. Right from conception, you see, if you look up there, having autistic sibling, advanced maternal or paternal age. We move on. You see that we have maternal obesity and or diabetes, exposure to traffic-related air pollutants, pesticides, maternal autoimmune diseases, prenatal infections when we get to prenatal area, and so on and so on. Labor induction, cesarean section has also been associated, and because perhaps maybe by the time people decide to do cesarean section, there's already a lot of insults that could have already gone on to the baby. Delivery complications, low birth weight. But there are also factors that have been found to be protective. Melatonin is a precursor for serotonin and dopamine. And it's that neurotransmitter that we all have that helps us to get to sleep. And sometimes we get people who are actually deficient in melatonin. And even children on the spectrum have a lot of sleep problems. And when we give them melatonin, they do well. Vitamin D supplementation, diet rich in fatty acids, omega-3 supplementation, folic acid, iron supplementation, breastfeeding. So we can talk about protective factors as well. So moving on, please warn me if I have a few minutes to go so that I do not keep people when they need to do other things. Okay, so clinical features. Often children show symptoms of autism within the first year. This is very often within the first year. Remember, it's a neurodevelopmental disorder. And a small number of children appear to develop normally, and we hear this in the clinic. In the first year, they say, there was no problem with the child. And then they go through a period of regression between 18 and 24 months of age when they develop autism symptoms. This we also see. but the reason behind that is not clear. Okay, so we have our clinical diagnostic criteria, which I will not bother you with. I've put it here just in case there are people who would want to look at clinically the diagnostic criteria for autism. But to break that down in a tangible manner, what we call deficits in social communication includes being able to initiate communication, and if someone else initiates, being able to respond. Yes? So we see children who range from no initiation at all. They do not initiate any social communication or social interaction. And then there are those who will initiate, but in a very bizarre manner. They'll come and slap you, and their peers will complain. So and so is just coming, he slaps us, and that is his way of initiating social interaction. And people then run away from them. Some of them bite. We've seen those who walk into the consultation room and they come and lick your hand, and that is their way of initiating. So it's atypical. So if another person initiates, the initiation is not returned. They are not engaged in social games or activities that require turn taking. And you hear parents come and say, this child plays alone, doesn't interact with anybody else. Yes. There is no response to speech, even when people are talking around and, they seem like, they're in their own world. When you call them, by the age of 6 months, if you've been consistently calling a child a certain name, by 6 months, they know this is my name, and they will turn if you call that name. So there is no response to a name. They have limited or no ability to initiate joint attention, to share interests or emotions, or to seek information about objects of interest in the environment. They do not point. We always ask, does this child point? They say, this child, how about bringing something they're interested in to show you? She doesn't do that. So you know that there is deficits in social communication. The second aspect is deficits in non-verbal communication behaviors. And non-verbal, 60% of communication, 65% actually, is non-verbal. And these are facial expressions, yes, posture, appearance, head movements. You can nod yes, nod no, yes. And children do that a lot. Even before they develop speech, they will refuse, and they have refused, yes. Hand movements like waving. By the age of 1 year, when you wave to a child, this is one of the things that we commonly, we wave to them when they're going out, and they will wave back if they're not on the spectrum. Eye movements, like winking, facial expressions, these children usually confuse us with their facial expression. You have a facial expression to show that you're surprised. For them, they will show surprise even when they shouldn't be surprised, Body contact, like shaking hands. I've just given you an example of this 15-year-old who I told to follow me, and he nearly walked between my legs. Then it's only 30% that we have verbal. So all these things, this non-verbal communication is kind of like their deficits in autism spectrum disorder. And lastly, in the social communication, there is deficits in developing and maintaining relationships. I think we've talked about this. They have no interest in peers. Naturally, remember we said we are hardwired to relate, to connect with others. So when you have a child who has no interest in the peers, peer interaction is difficult, and they have limited what we call pretend play, then they are having problems. We've talked about the restricted repetitive patterns of behavior, and I'll not go into that. But for that, for the first aspect, you need all the three.
We have lost you,
Okay.
Professor Catherine.
You've lost me? Hello?
Professor Catherine.
I think it's BHF is like, for me, I can hear you loud and clear.
Okay. Okay. Thank you. This we've talked about, but what I want to emphasize here is the someone is trying to say something. I continue?
I think you should continue. It's their network that is affecting them.
Okay, so the last aspect here that I want to bring out is the sensory reactions to sensory input. So they have either hypersensitivity to sensory stimuli or very low sensitivity to sensory stimuli. So they may have, for example, you will see a child who is forever closing their ears. Yeah, that might mean that the noise is too much for them. Or you put on a certain type of cloth like a jean and they cannot tolerate it, you know, while others can walk on fire because they have hyposensitivity to pain, for example. So it's important, and others might walk on their toes because they can't bear putting all their feet down. Yeah. So, early detection, why is it important? Early detection is important because it enables prompt intervention that may improve prognosis in a significant proportion of children with ASD. It, of course, clarifies the doubts and anguish of parents. The 15-year-old that we made a diagnosis in the other 2 weeks ago, the parents were so angry that this is the time that they're getting the diagnosis. But at the same time, they are relieved that now they have a reason why their son was doing certain things. It allows adequate public planning for future school placements, very important, and community support. And limits unnecessary shopping for solutions. The other one that we find it extremely handy is this early genetic counseling. It really bothers me if I see a mother who has walked in the clinic with 3 of her children, all of them on the spectrum. And the severe, you know, the next is more severe than the other, meaning that if some preventive measures were taken, perhaps even if they would be on the spectrum, the severity would be less. So the observation of a higher incidence of ASD among siblings of already identified cases has led to a more detailed examination of newborn siblings and follow-up during their first years of life in some research. So trying to identify early developmental signs that precede a diagnosis of autism in the siblings that eventually develop the disorder has been a fruitful area of investigation. So, so in the first 6 months, there were no notable findings, but after the first 6 months, in the following 6 months, social interaction problems started. So around about 6 months, there are things that could be picked. A child is not responding to the name and they're not maintaining eye contact and all these other things. So by 2 years of age, toddlers in the spectrum had clear problems in social communication, in play, in language and cognition, as well as other sensory and motor difficulties. These findings confirm the notion that ASD can be identified early than usual in some cases, and that for many children, 24 months of age coincides with a peak in new symptoms that would facilitate recognition. These are the red flags that you can look at, but what are the early warning signs in the first year? We know that every young infant, even young infants, are very social. So it's possible to detect signs of autism in how babies interact with their world. At this age, a child with ASD may not turn to the mother's voice. By the way, children hear their mother's voice, almost immediately after birth. So, but at this time, they may not turn to the mother's voice. They may not respond to their own name. They may not look at people in the eye, and they have no babbling or pointing by age 1, not smile or respond to social cues from the environment. So these are the very early warning signs in the first year. So you want to tell me that we cannot identify this? We cannot identify that the child is not turning to a mother's voice. We can't identify that the child is not responding to their name. We can't identify that a child is not looking people in the eye, and they are not bubbling, and they are not pointing because we're in the low resource setting. Really, I don't buy that. We should be able to do this. In the second year, the signs of autism are more noticeable in a child's second year. While other children are forming their first words and pointing to things they want. Yeah, they're pointing, and they're already saying, Mama, Dada, a child with autism remains detached. And then they'll say things like, this child is different. But anyway, there are many different people we live with. So this child is different. And they'll stay where they are. Yeah? But if a child has no single words by 16 months, yes, this is 1 year and 4 months, not so. By 16 months, a child has no single words. There is nothing like, this is what we hear. So if the child does not have pretend games by 18 months, pretend games simply means they use anything. They can get a cup and drive it as a car, for example. That is a pretend game. If the child has no 2-word phrases by 2 years, 2-word phrases, me, take, come, go, that kind of thing, by 2 years, then these are warning signs. If the child loses language skills that they already acquired, this is a warning thing. So no interest, if they have no interest when adults point at objects, yeah, say, look, something flying or a bird, and they show no complete interest at all, it's a warning sign. But we've got to know what else could it be. It's important to have this in mind, that in infants and toddlers, could it be a hearing loss? Actually, when parents come, they say, when there is that advert, that particular advert on TV, to come to the TV, yes? So then this is not hearing loss, but it has to be ruled out, either clinically, if you're not sure clinically, then you need to send them to ENT. So the differential diagnosis at this age should rule out disorders that interfere with normal development and language and social skills. And this can be suspected if the child has lost their babbling, they show poor vocalizations, or their indifference to auditory stimuli. The other thing that we have when we have this age group in the clinic is that some children who have severe psychosocial deprivation can present with symptoms or autistic-like symptoms. So severe emotional deprivation in childhood leads to serious psychological impairments, including pseudo-autistic clinical pictures. We sometimes see these children coming from orphanage because you know what happens in over, there's not enough stimulation there. So the autistic-like symptoms in these cases usually consist of relative indifference to the environment, communication delay, restricted interest, and repetitive behavior. So unlike in autism, social reciprocity is not completely abnormal. And although bonding may be affected and deficits can be reversed quickly in the majority of cases if environment improves. So it's important to, the other one is intellectual disability. But we also need to know that 50% of children on the spectrum may have intellectual disability. Although we have varying intellectual abilities, we have those on the side of intellectual disability, but then we have those who are also extremely intelligent. And there are those who have average intelligence. So it's important to note that when it comes to intervention, especially. It's difficult to separate the two, but those of us who sit in the clinic, we have
lost you. I don't know whether it's only me. Hello?
The others, can you hear me?
Doctor, continue. You're loud
Yes.
and clear.
Okay. The other one that we see is also selective mutism and separation anxiety. Children withdraw, they are anxious, they have communication problems, but because they will have these communication problems only in certain contexts and not every context, that will help us to differentiate. But when it comes to older children, we need to rule out childhood schizophrenia, attention deficit hyperactivity disorder that can coexist, obsessive compulsive disorder, and so on and so forth, and even anxiety. Now there are those disorders, as I mentioned, that can occur together with ASD. And this is why we really must do a thorough evaluation of children who are on the spectrum, because 70% of them also meet other diagnostic criteria for at least one other psychiatric, often unrecognized psychiatric disorder that further impairs psychosocial functioning. And some of these disorders respond very well to medication, although they cause symptoms of ASD may not. Another example there is attention deficit hyperactivity disorder that has proper medical treatment. So when do we suspect another problem? This should be suspected when the core features of ASD fails to explain the impairment. You know, you've identified the core features of ASD, but the impairment is so gross, then you may think that there might be something else that can explain the impairment. When there is noticeable change from baseline, they will say this child was not like this. He's now withdrawn. The other time he was able to, to laugh, but now he no longer laughs. And then there's something, maybe he's getting depressed. So when the patient is not responding to the therapeutic interventions as expected, then there might be some other problems. Now, quickly, we get into the interventions. So while there's no cure for autism spectrum disorders, intensive early treatment can make a big difference in the lives of many children. So for the core symptoms, the intervention is psychosocial intervention. And use of medicine has to be critically evaluated and indicated before it is prescribed. We don't just prescribe medication for these children. Now, we have barriers to intervention, even if we may not have first-class intervention services, there are still barriers. And the first one is the temptation to minimize the concerns. Yes, and these are some of the words we hear. It's because the commonest we hear is that it's because the house girl would put the child in front of the TV and just leave the child there. It's because the house girl mistreated the child. It's because, you know, and then he will be fine or she will be fine. You are worrying too much, yeah? It's because you went back to work too soon. You are too easy on her. Yes? He's just slow, yes? You are too soft on him, and so on and so forth. So we should not minimize concerns. After all, there are concerns which can be properly evaluated, and if found to have nothing, then you tell the parent. But you don't tell the parent not to have concerns before you properly evaluate. Now, the focus of intervention arises from whatever deficits that may have been identified. So you see where the evaluation is key. There is no way you're going to identify these deficits if evaluation is not done. So evaluation must be done to identify the deficits. And then build better communication skills. And there are ways of building these better communication skills. Teach joint attention skills. There are some of the things that we do in our clinics, like play and imitation. Manage repetitive behaviors. Manage sensory issues. Develop activities of daily living and improve physical movements, improve speech. Those are really the focus of intervention, which must arise from the deficits that come after evaluation. I want to talk about indicators of effective treatment or effective interventions, programs or institutions. What is it? Because parents ask, can you please recommend? And we really do not have, we used to have like one or two that we knew did the proper things and you know, they had all this, but with time, they got overwhelmed and they are now no longer doing what they need to be doing. So this is what we tell parents, that look for an institution that will carry out appropriate assessments to identify your child's needs. There is no assumption of the needs of the children. They must be identified. Then there has to be individualized intervention plan and not one size fits all. Yes? So you identify the needs and then you have the plan for that particular child to address those needs. This person, you cannot identify the needs and make up the intervention plan if you do not understand how the brain develops. So there has to be some understanding of brain development and milestones and tasks. Then the interventions has to be those interventions that increase development of new skills and behaviors. They have to be those interventions that get rid of problematic behaviors and interventions that have positive reinforcement that can be reinforced at home, at school, and outside. So those are the kind of interventions. And then you ask yourself, who are these people giving this intervention in terms of qualifications and experience? It's very unfortunate that we have not had enough pool of people who are properly qualified and experienced to handle children with ASD, and therefore they are mushrooming. Everybody gets up and thinks now they can handle, and then they cause a lot of what we call it, bad effects on the child. So there are also red flags for ineffective treatment. Those that are not approved in studies to be effective. Yes. If you go to an institution where they give intervention for these children and they are not collecting data to track the child's behaviors, sometimes when they bring the child to me for assessment, I want to know what can I see how this child has been progressing in eye contact? They have to track the child's behaviors and skill levels to determine the cause of treatment. If they just put children in one room and they're showing them TV and actually it's harmful if that is done. Then usually there are people who are training, and if there's no supervision of young inexperienced practitioners, then you know they might cause harm to the children. If there are no individualized intervention plan, you go to an institution and you ask, can I see a plan for my child who is 2 years? And there's no plan. How about my child who is 6 years? And there's no plan. How about for adolescents? No plan. How about for adults? No, sir, no plan. So if they give same treatment, regardless of their needs, there's a problem. If they lack positive reinforcement techniques, there's a problem. If they use punishments, actually I've been to some of these institutions and they use punishments. As you know, in our society, punishment is something that is next to, even when people are sleeping, they think punishment is what should be given. And therefore, even to these children, they use punishment. There is a problem. If there's no team work and there's no multidisciplinary approach. Usually I tell the mothers, please check if there's a speech therapist in that institution, check if there's an occupational therapist, check if there's a behavioral interventionist, check if there's a special needs teacher, check if there's a clinician, check if so they go and at least if they have 60% of the needed multidisciplinary approach, then perhaps they can take on. Now, we've talked about preventive strategies. This very tiny table just tells us what we need to do, the clinical recommendations during preconception period, how to minimize the risks and maximize protective factors on the other hand. So you have preconception period, you have perinatal period, you have early postnatal period. So what are the challenges and opportunities for early identification and intervention? The challenges that we've seen is delay in seeking help. Where does this come from? First, remember, we have to to be fair here. We talk about deficits. Deficits, if someone said, I have a deficit of 100,000 in order for me to pay for this thing, simply means that thing costs maybe 200,000 and they don't have their 100,000. So in autism, we are talking about things that are not there. And for us, we know, and we've been trained, and even in our societies, we look for things that are there. A child has fever, you touch the child is hot, and therefore you run to the health center or wherever, yes? So beginning to look for what is not there, what are you looking for? It becomes a big challenge. And that, I think, contributes to delay in seeking help. The second thing is that even when we come to that realization and we have concerns of delays, delay in speech, delay in doing that, we begin to ask people we know, our neighbors, friends, relatives, and they'll say, as already said, they minimize. So they will give you evidence that you don't have to worry, and then that continues. Then when time, unfortunately, even as health workers, we've got parents who come and tell us, you don't have to worry about, or that kind of thing. So anyway, so there is that there. Then the issue will come about the burden of infectious diseases to both the parents and the health worker. The health worker doesn't have time to observe. We take time. We can even do this evaluation 1 hour, 2 hours, you know, up to 3 months. We are still trying to understand if this child is on the spectrum or not. So you can tell me that if you have 100 patients lined up, where are you going to have time to be able to, you know, to look for these deficits? And for the parents, infectious diseases kill. And so they'll run very fast. But even when they know the child is on the spectrum, it's not going to kill the child. That can wait. And then where to seek help? Where do I go? Yes. There are various places. The mental health regional mental health units have people who have been, you know, trained, diploma in child and adolescent mental health. They have skills. They can identify these children, and then limited expertise in the area. We've talked about that, and then limited appropriate school placement. So the opportunities we have are to raise awareness. If we are having infant mortality improving, is it improving? Yes, I think so. That means there will be improved livelihood. I mean, children will not many children will die during infancy. Therefore, we must begin to think about their quality of life. Training more health workers, identifying referral pathways, regional mental health units, Mulago Bosa Mental Health. My infant mental health clinic in Ward 15 runs on Mondays. I see only below 5 years, and that was to raise awareness about early identification and early intervention. In the beginning, it was very challenging, but with time, we have been settled there for 2 years. And we are thinking about how to make it better and better. Then there is Butabika Children's Unit, where we also see children. I volunteer there once a week. And then KCC Energy Blue has a project that is running for children with special needs. And sometimes children we see from Mulago, we actually refer them to KCC Energy Blue for prolonged intervention. Okay, I think that was the last slide. Thank God I went up to the end. Thank you so much. I think I've taken much of your time, but we can open up. Yeah, thank you.
Wow, wow, wow. Thank you very much, Catherine. Despite your ill health, thank you for giving us this very interesting and important topic, because I think most of us here, we are parents, but from your talk, I think we shall be able to advise accordingly without wasting time. But sincerely, can't we give her a thunderous hand clap, even virtually? Can we? Yes. Thank you so much. The person is sick, but she kept on. Thank you. Thank you, Professor, for this presentation. We are privileged to have our the Vice Chairperson for Busoga Health Forum Board. You are most welcome, Dr. Shibagita. But before, I request her to give closing remarks, but before she does, Elizabeth, please help us with the questions